Okay, happy Tuesday, happy Tuesday. This is a continuation of the 2/24/2020 Monday reading folder. Risk conditions. Yesterday I did the upper and lower limb tension test video. It was an hour long. It had the Maggie risk condition reading part on there. If I'd known it was going to be that long, I would have separated that. So we will skip the upper limb tension test part of this. Go down to, let's see, the hands. Here we go. Wrist and hand. Here's the nodes over here. Different nodes. Brokered and Herberton nodes. Notice that they're at different parts of the digits. So you have the metacarpal and the proximal phalange. And here it's in between two phalanges, the proximal and the distal phalange. And then over here on C, we have degenerative joint disease, osteoarthritis of both hands. Osteoarthritic enlargement of the distal interphalangeal joints is the Heidergen nodes, and the proximal interphalangeal joints, the Dochard nodes, is present. The metacarpophalangeal joints are not infected. So, kind of low energy today. The most common deformities occurring in rheumatoid arthritis are ulnar drift and palmar subluxation at the metacarpophalangeal joints. Note swan neck and boutonniere deformities present in the digits. And we'll go over that in a little bit. On figure 711, it shows the spoon-shaped nails. Figure 712, clubbing of the distal interphalangeal joints and rounding of the nails in a patient with hypertrophic osteoarthropathy. Up here. Interesting. Close-up side view of the index finger. And then B is the dorsal aspect of both hands. Wow. I don't think I've ever seen. I've seen fingers, the nail bed, similar to that, but interesting. Okay, table 7.2, glossary of nail pathology. Bow lines, transverse lines or ridges marking repeated disturbances of nail growth. Systemic diseases, toxics or nutritional deficiency states of many types, and trauma. That's an interesting word. I'm not going to even attempt to say it. Complete loss of nails. And you can see that in systemic diseases such as scarlet fever, syphilis, leprosy, and some exfoliative dermatitis. Diffusion of the lanula, eggshell nails. Lots of words I don't want to pronounce, so let's go on. Here we go. Glossary of nail pathology. I'm not going to spend too much time on this. Ape hand deformity. Wasting of the thenar eminence of the hand occurs as a result of median nerve palsy. And the thumb falls back in line with the fingers as a result of pull of the extensor muscles. The patient is also unable to oppose or flex the thumb. Bishop's hand or benediction hand deformity, wasting of the hypothenar muscles of the hand, right here, the interosseous muscles, and the two medial lumbrical muscles occurs because of ulnar nerve palsy. Flexion of the fourth and fifth fingers is the most obvious resulting change. Drop wrist deformity. The extensor muscles of the wrist are paralyzed as a result of radial nerve palsy. And the wrist and fingers cannot be actively extended by the patient. Claw fingers. This deformity results from a loss of intrinsic muscle action and the overaction of the extrinsic long extensor muscles on the proximal phalanx of the fingers. The metacarpal phalangeal joints are hyperextended, and the proximal and distal interphalangeal joints are flexed. If intrinsic function is lost, the hand is called an intrinsic minus hand. The normal cupping of the hand is lost. Both the longitudinal and the transverse arches of the hand disappear. There is intrinsic muscle wasting. The deformity is most often caused by a combined median and ulnar nerve palsy. Boutonniere deformity. Extension of the metacarpal phalangeal and distal interphalangeal joints and flexion of the proximal interphalangeal joint, primary deformity, are seen with this deformity. The deformity is the result of a rupture of the central tendinous slip of the extensor hood and is most common after trauma or in rheumatoid arthritis. Dupuytren contracture. This progressive disease is of genetic origin, results in contracture of the palmar fascia. There is a fixed flexion deformity of the metacarpal phalangeal joints and proximal interphalangeal joints. Dupuytren contracture is usually seen in the ring or little finger, and the skin is often adherent to the fascia. It affects men more than women and is usually seen in the 50 to 70-year-old age group. Mallet finger. A mallet finger deformity is the result of a rupture or avulsion of the extensor tendon where it inserts into the distal phalanx of the finger. The distal phalanx rests in this flexed position. Swan neck deformity. This deformity usually involves only the fingers. There is a flexion of the metacarpal phalangeal and distal interphalangeal joints, but the real deformity is extension of the proximal interphalangeal joint. The condition is a result of contracture of the intrinsic muscles or tearing of the volar plate. It is often seen in patients with rheumatoid arthritis or following trauma. This is a palmar view showing the pathomechanics of a common zigzag deformity of the thumb caused by rheumatoid arthritis. The thumb metacarpal dislocates laterally at the carpometacarpal joint, right here, causing hyperextension at the metacarpophalangeal joint, here. The interphalangeal joint remains partially flexed owing to the passive tension in the stretched and taut flexor pollicis longus. Here. Note that the bowstringing of the tendon of the extensor pollicis longus across the metacarpophalangeal joint here creates a large extensor movement arm, whereby magnifying the mechanics of the deformity. There's the bow lines. That was on that other. There's the pin rolling hand, Parkinson's disease. Opera glove anesthesia. And here's box 7.1, outline of physical findings in the hand. I'm not going to spend too much time on that in the video. And this is the therapy ed part of the reading. And I added a bunch of slides from my lecture, my school content. So, wrist and hand conditions, carpal tunnel syndrome, repetitive stress syndrome. Compression of the median nerve at the carpal tunnel of the wrist due to inflammation of the flexor tendons and or median nerve. Commonly occurs as a result of repetitive wrist motions or gripping with pregnancy, diabetes, and RA, rheumatoid arthritis. Must rule out potential of cervical spine dysfunction, thoracic outlet syndrome, or peripheral nerve entrapment that mimics this condition. So cervical spine dysfunction, thoracic outlet syndrome, and peripheral nerve entrapment is going to be differential diagnosed issues you want to deal with. Diagnostic test utilized is electrodiagnostic testing. Common clinical findings include exacerbation of burning, tingling, pins and needles, and numbness into the median nerve distribution at night, and a positive Tinel sign or Phelan's test. Long-term compression causes atrophy and weakness of the thenar muscles and lateral to lumbricals. Medications taken for this condition is acetaminophen for pain and NSAIDs for pain and or inflammation. Physical therapy goals, outcomes, and interventions. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization to the specific restrictions identified during the examination. Soft tissue massage techniques, modalities, flexibility exercises, and functional exercises including strengthening, endurance, and coordination. And these are slides from my school content. It's the most common peripheral nerve entrapment syndrome. The carpal tunnel consists of 8 extrinsic tendons and the median nerve. Any condition that can decrease cross-sectional area of the cause, sustained flexion extension postures, repetitive movement, distal radius fractures, medical conditions such as pregnancy, peripheral neuropathy associated with diabetes, renal disease, and alcoholism. And just like the other slide stated, RA, rheumatoid arthritis. Symptoms: pain, paresthesia, or numbness in the median nerve distribution, which is this blue part here. Frank weakness and thenar atrophy do not occur until later in the disorder. Shaking their hands makes it feel better. So special tests: C, a PT for carpal tunnel; C, compression flexion test, Phelan's and Tunnel's. And EMG positive is the diagnostic test, which this stated here, electrodiagnostic testing. Here is the compression flexion test. Hold the hand in supination and flex wrist 60 degrees. Maintain constant pressure over the medium nerve at the carpal tunnel. Positive test is if symptoms are reproduced. Phelan's. Patient asked to hold forearms vertically. Allow both hands to drop into complete flexion at wrist. Maintain up to 60 seconds or until reproduction of symptoms. Tunnel's. Wrist held in neutral. Use index finger or reflex hammer to tap where medium nerve enters the carpal tunnel. Positive if paresthesia along median nerve distribution. Several variations, but ensure to tap slightly proximal to the carpal tunnel. Treatment for this is eliminate or minimize aggravating factors. Patient education, trying to keep wrists in neutral positions, take rest breaks, avoid prolonged pressure. There's actually a splint, Lancer splint, keeps the wrist in neutral. Mainly indicated at night, however, patients may attempt to use with ADL's work if able to. Nerve glides, ultrasound, hot pack paraffin, soft tissue cross-friction massage, NSAIDs, cortisone, treat underlying medical condition like RA. The carpal tunnel syndrome surgical technique: post-op rehab, remove dressings 3 days after surgery, light active range of motion and tendon gliding. No forceful gripping for 2 to 3 weeks to prevent bowstringing. Suture removal 10 to 14 days. Light resistance after 2 weeks. Return to work 2 to 6 weeks. Board question: a 34 female in her second trimester went to physical therapy. Complaints of tingling, loss of strength in both her hands. Her symptoms are exacerbated if she is required to use her keyboard at work for longer than 20 minutes. The most appropriate physical therapy intervention would include, modalities which use steroids are contraindicated for pregnant women. The most effective treatment would be to place wrist in a neutral position in splints. Carpal tunnel is therefore not comprised by poor hand positioning while at work. Now we are moving to de Quervain's tendinovitis. Oops. This is where you're going to have inflammation, degeneration of the extensor pollicis brevis and the abductor pollicis longus at the first dorsal compartment. Results from repetitive microtrauma or as a complication of swelling during pregnancy. Diagnostic tests: utilized MRI, but usually not necessary to make diagnosis. Clinical signs include pain at anatomical snuff box, swelling, decreased grip and pinch strength, and a positive Frankenstein's test, which places the tendons on a stretch. Medications, acetaminophen for pain, NSAIDs for pain and or inflammation. Physical therapy goals, outcomes, and interventions. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization to the specific restrictions identified during the examination. Soft tissue massage techniques, modalities, flexibility exercises, and functional exercises including strengthening, endurance, and coordination. And here's the extensor pollicis brevis and the abductor pollicis longus. Inflamed sheaths underneath the extensor retinaculum. Inflammation of the synovial sheath, the abductor pollicis longus, and the extensor pollicis brevis. Mechanism of injury, repetitive use, thumb and wrist extension. Example, using scissors, often lifting a toddler. Symptoms, pain and swelling around the radial styloid process. Discomfort with thumb movement. Special test, Frankenstein. Make a fist with the thumb inside the fingers. Ulnarly deviate. Positive is pain of the abductor pollicis longus and the extensor pollicis brevis, tendons at risk. Indicative of peritendinitis. Goal is to decrease inflammation, to allow tendon to glide smoothly under extensor retinaculum. Education, activity modification as able. Graded exercises, cortisone injection, NSAIDs, modalities such as ice, heat, ultrasound, phonophoresis, ionto. Not sure what that stands for. IO. Forearm base spica splint, over the counter versus custom, rigid versus soft. Surgical treatment involves incising the retinaculum and first extensor compartment to create more space for the tendons. Post-operative starts 2 days afterwards. Remove dressing. Graded exercises as tolerated. Want them to use. Avoid scar down, so that you want them to use it. Avoid scar down. Board question. Patient complains of persistent wrist pain after painting her house 3 weeks ago. Positive Frankenstein's test, pain and swelling at the anatomical snuff box, decreased pinch strength. Effective plan of care should include ionto, desensitization techniques, gentle active range of motion exercises, phonophoresis. The symptoms suggest occurrence. Effective treatment should include modality to reduce inflammation of the tendon sheaths. In this case, phonophoresis. Other choices include incorrect diagnosis. Carpal tunnel, reflex sympathy dystrophy, and gamekeeper's thumb injury. So it's important to know. Positive Frankenstein. So what does that test? If it's positive, what does that tell you? So that's why these 3 are incorrect, because it's the wrong diagnosis. Cole's fracture. The most common wrist fracture resulting from a fall onto an outstretched upper extremity. These fractures are immobilized for 5 to 8 weeks. Complication of median nerve compression can occur with excessive edema. Characteristic dinner fork deformity of wrist and hand results from dorsal or posterior displacement of distal fragment of radius with a radial shift of the wrist and hand. Diagnostic tests utilize plain film imaging. Complications may include loss of motion, decreased grip strength, compartment regional pain syndrome, and carpal tunnel syndrome. Medications: acetaminophen for pain, NSAIDs for pain and or inflammation. Physical therapy goals, outcomes, and interventions. Early physical therapy intervention that focuses on normalizing flexibility is paramount to functional recovery of the wrist and hand. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization to the specific restrictions identified during the examination. Soft tissue massage techniques, modalities, flexibility exercises, and functional exercise, including strengthening, endurance, and coordination. And here's your Cole's fracture. Most common: distal 1/2 to 2 inches of the radius. And here, usually a dorsally angulated distal fragment, like a silver fork. Interesting. Distal radial fractures, most commonly fractured bone in the body. Cole's fracture, most common: distal 1/2 to 2 inches of the radius with dorsally angulated distal fragment, silver fork. Swoosh injury, signs: swelling of the wrist with potential deformity, focal point tenderness, and limited range of motion. So there you go. Smith's fracture, similar to Cole's fracture, except the distal fragment of the radius dislocates in a volar direction, causing the characteristic garden spade deformity. Diagnostic tests utilize plain film imaging, medications, acetaminophen for pain, NSAIDs for pain and or inflammation. Physical therapy goals, outcomes, and interventions is similar to the Cole's fracture. Let's see if we can find a picture of that. Because none of the books had it. None of the textbooks had it. So here's a nice little image here. Ooh. Hey. Outward, inward. That's interesting. So let's go ahead and copy this out of here. Interesting. I want to see that other view though. I want to see this view. So Cole's over here, and a Smith fracture. Okay. Alright, one more. Let's see what else we can find before we move on. What's this say? A flexion fracture of the radius, extension fracture of the radius. My book didn't tell me that. So Smith is flexion, SF, and Coles is extension, C. So SF versus CE. That's how I gotta remember stuff, just in case. If it's relevant, you never know. Helps me remember. Okay, scaphoid fracture. Moving on. Results from a fall onto an outstretched upper extremity in a younger person. Most commonly fractured carpal. I'm not so sure it has to be a younger person. I don't know. It could be. I don't know. Diagnostic tests utilize plain film imaging. Complications include a high incidence of avascular necrosis of the proximal fragment of the scaphoid, secondary to poor vascular supply. Carpals are immobilized for 4 to 8 weeks. Medications, same thing. Physical therapy goals, outcomes. Early intervention includes maintenance of flexibility of distal and proximal joints while upper extremity is casted. Later interventions emphasize strengthening, stretching, joint and soft tissue mobilizations to regain full function use of the wrist and hand. Scaphoid, right here. Swoosh injury, most frequently fractured carpal bone, commonly misdiagnosis. High incident of suspicion with wrist injuries until can rule out scaphoid fracture. Symptoms are dull, deep wrist pain, snuff box tenderness. X-rays, false negatives. Treat until you can rule out definitely. CT, bone scan, MRI. Controversial treatment. Location is key. Proximal pole, 16 to 20 weeks in short or long-term spica. Central third, 6 weeks in long arm thumb spica, followed by 6 more weeks in a short arm thumb spica. Distal third, 6 to 8 weeks in a short arm thumb spica. Tuberosity, 5 to 6 weeks in a long or short arm thumb spica. So here again, that proximal pole is your problem because it's avascular. High incidence of avascular necrosis of the proximal fragment of the scaphoid, secondary to poor vascular supply. Okay, I gotta pause here because my dog wants to go out. Okay, resuming. We went there. Non-union, 8 to 10% of the time. Location, proximal third, 20 to 30% of the time. Middle third, 10 to 20% of the time. Distal third, very rare. Proximal, also more likely to require surgery. If operative treatment, may still require immobilization up to 3 months until radiographic union. Potentially spike a splint for another month. Union rate. Let's make this bigger. Okay. Distal, waist, proximal. Proximal here. And that's the union rate. Dupuytren's contracture. I'm very familiar with this diagnosis because I have it in both my hands. However, I do not have a contracture yet. The worst time for me is in the morning because I sleep with my hands like this. So in the morning I have to stretch it out. Observed as banding on palm and digit flexion contractures resulting from contracture of palmar fascia that adheres to the skin. Affects men more than women. Contracture usually affects the metacarpal phalangeal and the proximal interphalangeal joints of the 4th and 5th digits in non-diabetic individuals, and affects the 3rd and 4th digits most often in individuals with diabetes. That's interesting. Same medications. Physical therapy goals, outcomes, and interventions includes flexibility exercise to prevent further contracture and splint fabrication and application. Totally agree with that. Yoga positions are a really good way to stretch out the hand, wrist. Once contracture is under control, promote restoration of normal hand function through functional exercise. Physical therapy intervention following surgery includes wound management, edema control, and progression of functional exercise. Progressive fibrosis of palmar aponeurosis. Flexion contractures of the Np and Pip joints, typically 4th and 5th digits, and web space contractures. Dominant gene of Northern European descendants, epilepsy, diabetes, alcoholism. Don't have any of those 3. Men to women is 8 to 1. That's interesting. Often bilateral. Mine is. Yep. Treatment, therapy often not helpful. I don't agree with that because I have a personal history with this, and I think stretching is extremely helpful. Extremely helpful. Surgical, not common. Very complex surgery. Fasciectomy. Wound is concerned and closely monitor. Active motion with goal of full extension within 2 weeks. If full extension is not achieved in 2 weeks, then start splinting. Balance between improving motion but not over tension on the wound. Scar massage once tolerated. 3 weeks post-op, progressive stretching and resistance. You need to follow the surgeon-specific guidelines and individualize each patient treatment. Boutonniere deformity results from rupture of central tendinous slip of extensor hood. Observed deformity is extension of MCP and distal DIP with flexion of PIP. Commonly occurs following trauma or in rheumatoid arthritis and degeneration of the central extensor tendon. Same meds. Interventions include edema management, flexibility exercises of involved and uninvolved joints, splinting or taping, functional strengthening, endurance, and coordination exercises. Boutonniere deformity. I actually made a Control C. I want to delete that from here. And let's add a slide. Oops, I don't want that kind of slide. I want a blank slide to put my table that I made. And I made this table a long time ago. Having a hot flash. Okay. Whoever's watching this will get to see how I make my videos. I make these videos mainly for my own benefit because I like to watch them over and over again. Okay. So typically traumatic, common extensor tendon damage and the central slip, hyperextended DIP, distal interphalangeal. So here it is hyperextended. See that hyperextension? Causes lateral bands of central slip to drift forward and past axis of rotation. Looky here. I like that picture. Orientation changes from flexors to extensors. So, metacarpal phalangeal joint is extended. See that right there? And the proximal interphalangeal is flexed. So extended, flex, extended. So extended, flexed, extended. So EFE. EFE. Okay? So boutonniere is EFE. Put that up here. So extended, flexed, extended. Boutonniere. Oops. No, you can put that on there. That's not a problem. We can put that on there. Okay. So extended, flex, hyperextended, extended, whatever. So if mobile correctable deformity, immobilize the PIP in full extension 6 to 8 weeks. So you're immobilizing the PIP right here. The DIP and MCP are free. Gentle range of motion at 4 to 8 weeks. Maintain splint between exercises. Strengthening at 10 to 12 weeks. Swan neck deformity results from contracture of intrinsic muscles with dorsal subluxation of lateral extensor tendon. Observed deformity is flexion of the MCP and DIP and extension of the PIP. So we can put that up here too. My little chart. So the MCP is flexed. The DIP is flexed, and the PIP is extended, hyperextended or extended, whichever. So, flexed, extended, flexed. So, FEF. So, the swan neck is FEF. Commonly occurs following trauma or with rheumatoid arthritis following degeneration of lateral extensor tendons. Diagnostic tests, plain film imaging, but may not be necessary. Same medications. Therapy goals, edema management, flexibility exercises of involved and uninvolved joints, splinting or taping, functional strengthening, endurance, and coordination exercises. Swan neck. So flexed. Let's move in. It's okay. I'll put it right there. Yeah. So, flexion of the DIP, hyperextension of the PIP, destruction of the oblique retinacular ligament of extensor mechanism leads to posterior displacement of the lateral band of the extensor mechanism. So, flexed, extended, flexed. Swan neck, inability to bring finger in to grasp, more debilitating than a boutonniere. Mechanism of injury, most commonly result of RA, can be trauma. And here's a tri-point splint right here. Interesting. Ape hand deformity observed as thenar muscle wasting with first digit moving dorsally until it is in line with second digit. Results from medium nerve dysfunction. I'm going to pause for a second. Okay, so I took a little break, pause to go to my atlas. So here's the thenar eminence, right here, the thenar muscles next to that thumb, thenar thumb. The medium nerve, thenar thumb, right there. Okay. So, medium nerve dysfunction. So let's go ahead and let's look at the atlas. Look at the medium nerve right here and how it innervates the thenar muscles right here. Palmar branch. And right there. There it goes, medium nerve into the hand. So while we're at it, why don't we go ahead and review what the median nerve innervates. Okay. So the flexor carpi radialis, the flexor digitorum profundus, the lateral part, the medial part is the ulnar nerve. The lateral part is the medium nerve. The flexor digitorum superficialis is the median nerve. Flexor pollicis brevis, flexor pollicis longus. The lumbricals first and second, opponens pollicis, palmaris longus, pronator quadratus, pronator teres, and that's it. So, here we go. Acan deformity, medial nerve dysfunction. Mallet finger. Rupture or avulsion of the extensor tendon at its insertion into the distal phalanx of digit. Observed deformity is flexion of the DIP joint here. Diagnostic test, possibly the MRI, medications, the same. Therapy, edema management, flexibility exercises of involved and uninvolved joints, splinting or taping, functional strengthening, endurance, and coordination exercises. The mallet finger, zone 1, right here. Rupture of the extensor tendon of the distal interphalangeal joint, most common in sports. Point tenderness and swelling over the distal joint and lack of active extension. Immobilization in slight hyperextension, 6 to 8 weeks. Orthoplast splint, after 8 weeks, remove and use with heavy activities, or if it has an extension lag. Begin light active range of motion at 8 weeks. If you begin to develop an extensor lag, then must resume use of the splint. Note if laceration and surgical repair. Gamekeeper's thumb. A sprained rupture of the ulnar collateral ligament of the MCP joint of first digit. Results in medial instability of the thumb. Frequently occurs during a fall while skiing. When increasing forces are placed on thumb through ski pole. Immobilized for 6 weeks. Diagnostic tests, possibly an MRI, medications are the same. Therapy goals, edema, management, flexibility exercises involved and uninvolved joints, splinting or taping, functional strengthening, endurance, and coordination exercises. So, gamekeeper's thumb, UCL sprain, ulnar collateral ligament. Torn ulnar collateral ligament right there at the MCP, metacarpal phalangeo joint right there. Traumatic mechanism of injury, signs and symptoms, pain or tenderness over ulnar aspect of the MCP, positive stress test. Typically split in 2 categories, grade 1, microscopic tear, and grade 2, partial tear, sprains. Grade 3, sprains, surgical, a full tear. Grade 1 and 2, majority of ligaments still intact, stability testing at full extension and 30 degrees of flexion. Stresses accessory collateral ligament and the ulnar collateral ligament, respectively. Angulation greater than 35 degrees or 15 degrees greater than non-involved side indicates instability and surgical intervention. The ulnar collateral test, stabilize hand with one hand. Take thumb into extension with the other hand. While maintaining thumb extension, apply a valgus stress to the MCP joint to stress the ulnar collateral ligament. Positive test is pain or increased movement compared to the uninvolved side. See MedBridge. Please note, as positive has also been described as movement greater than 30 degrees. So it has a pretty snout, 94%. So the UCL test is negative, it rules it out. Immobilization, thumb spica cast for 3 weeks. Immobilizes the wrist, the MCC and the MCP. Carpal metacarpal and metacarpal phalangeal joint. Splinting for an additional 2 weeks. Ensure that the superficial radial nerve and ulnar digital nerve are not compressed. This is a grade 1 and 2 sprain treatment. Look for potential pressure areas. Splint worn at all times except hygiene and exercise. Active range of motion at week 3. Strength at week 8. No abduction stress at metacarpal phalangeal for first 6 weeks. Grade 3 and bony avulsion tears. Surgical. Surgeon preference on technique. Post-operatively variable. In general, continuous immobilization for 3 weeks. Begin active range of motion approximately 3rd week. Continue to spica splint 2 additional weeks. Slowly progress as tolerated. Boxer's fracture. Fracture of neck of 5th metacarpal. Frequently sustained during a fight or from punching a wall in anger or frustration. Casted 2 to 4 weeks. Diagnostic test, plain film imaging, medications the same. Interventions, edema management, flexibility exercise, initially at uninvolved joints, followed by involved joints after sufficient healing has occurred. And then initiation of functional strengthening, endurance, and coordination occurs when flexibility is restored. Almost done. Boxer's fracture, most common metacarpal fracture. Displaced 5th metacarpal neck. Some angulation is acceptable, 15 degrees at the 2nd met, up to 50 in 5th met. Hand-based ulnar gutter splint, 2 to 3 weeks. MP in 80 degrees of flexion, leaves IP free. Metacarpal phalangeal joint is in 80 degrees of flexion and leaves the IP interphalangeal free. Digit, range of motion in split, once pain resolves, buddy tape. If surgeon feels unstable, may use percutaneous pen. Immobilize in ulnar gutter cast or splint. Metacarpal phalangeal joints flexed, MP joints flexed, and IP extended. Trigger finger thumb, stenosis, inflammation, fibrosis, thickening of digital flexor tendon sheath in area of A1 pulley. Tendon is most subjected to tension and friction. Symptoms snagging or triggering when attempted to extend from fully flexed position. Classic symptom, finger locked, requires self-passive extension. Mechanism of injury, idiopathic or repetitive use, palpation. Nodule proximal to A1 pulley. Place finger on A1 pulley, have them flex and extend. Trigger finger goal, decrease inflammation to allow tendon glide smoothly through pulley. Hand-based or finger splint position, MP joint at 0. Allow full PIP movement. Education, activity modification as able, graded exercises, modalities, ice, heat, ultrasound, phonophoresis. cortisone injection NSAIDs. Releases A1 pulley. I'm going to pause and see if I can find us a picture of an A1 pulley. Okay, so area of the A1 pulley. So let's look at some pictures here. Here's the A1 pulley right here. So you've got proximal, middle, distal, phalangeal, metacarpal. So it's right at the end of the metacarpal. Right at the end of the metacarpal. That's a swollen synovium. Swollen synovium. And this is the pulley system. So you got the node of the flexor tendon right here. Triggering effect due to the tendon nodule squeezing through tight A1 pulley. So your nodule of the flexor tendon right here. Here's the A1 pulley right here at the end of the metacarpal. So that node is swollen, and so it's trying to pull through the A1 pulley here, the flexor pulley, and it's not able to squeeze in there. So it's triggering. That's what it looks like. A1, A2. Wow. Here's a nodule. So to extend the finger, this nodule has to go through the A1 pulley to extend it. That's interesting. Okay. So the goal is to decrease inflammation to allow tendon to glide smoothly through the pulley. That makes a lot of sense, right? Hand-based or finger splint positions, Npte joint at 0 degrees. Allow full proximal interphalangeal joint movement. Activity modification as able. Heat, ice, ultrasound, phonophoresis, cortisone injection, and NSAIDs. Surgical treatment releases the A1 pulley. Post-op, PT starts 2 days afterwards. Remove dressing, range of motion, Pacific. Tendon gliding at 2 weeks. Want them to use it so it doesn't scar down. Scar massage, ultrasound, heat, and ice. And there you go. There's the tendon sheath, the swollen synovium, and the inflamed tendon. Open the tendon sheath. Probably the A1. Releases the synovium and releases the tendon. Owie. Alright, this is lower extremity. This was part of the PDF, but I'm sure it was, we're not going over that, so let's just delete. Delete. Okay, and save. And that is the hand and finger deformities.